Assalamu alaikum. My name is Dr. Mohammad Farhan. Today the topic of our discussion will be cervical traction and timing of surgery after spinal cord injury. So we are going to discuss the cervical traction and its objectives and its purpose in spinal cord injury, and we are also going to review the indications and contraindications of cervical traction, understand what are the different types of cervical tractions, and how to apply the cervical traction, what are the different techniques, and recognize complication and post-op placement care of cervical traction. And then we are going to have a look over the uh, different timings of surgeries, early or versus late in spinal cord injuries. So first of all, the purpose of cervical traction is to realign and reduce the cervical fracture dislocation that restores the normal anatomy. So when a fracture is dislocated, so the purpose is to the realignment of the normal anatomy, uh, the asymmetrical anatomy of the fracture and dislocation. So when cervical traction is applied, the fracture fractured body or the dislocated fracture is uh, uh, comes to a place by after applying the resistance, and then after applying the resistance and keeping it in its position, it provides a healing time for the fracture dislocation. Then there is a indirectly compress the cord, decompress the cord by restoring canal diameter. When we apply the cervical traction, the cervical cord and spinal nerve roots are decompressed, and it provides space for them. Then it also restores the and maintain cervical sagittal alignment, and then temporary splinting of the unstable segment before surgery, and intraoperative distraction such as when operating a ACDF or when doing a corpectomy, anterior cervical corpectomy. Then cervical traction can also be applied intraoperatively, and usually this is achieved by the manual cervical traction. Then these are the different indications of the cervical traction, such as subaxial fracture dislocation, unilateral or bilateral facet joint dislocations. Usually, the cervical traction is not applied when there is a fracture of the atlanto-occipital or the atlantoaxial joints or these vertebra C1, C2. But cervical traction is usually indicated in the subaxial fracture dislocation. That is the main indication of cervical traction. Then cervical malalignment requiring a closed reduction, and unstable injuries needing temporary stabilization, reduction of selected odontoid or C1 C2 fractures. Usually C1 C2 fractures are not but in selected cases it can be applied. Then there is intraoperative cervical distraction that we have discussed, that during ACDF or ACCF we can apply the intraoperative cervical distraction. Then there are some absolute contraindications such as the craniocervical or the atlanto-occipital dissociation. That is a absolute contraindication. Then distractive ligamentous injury when seen on imaging. Then type 2A and 3 hangman fractures that are usually in the C2 and C1 fractures. And then skull fracture or defect at the intended pinch sites. When applying the cervical traction, there are specific sites at which the pins are applied to the cranium. When these sites are fractured, then cervical traction may not be applied properly. Control cannot be achieved with cervical traction. Then we should not apply the cervical traction, and we can achieve the stabilization by some other methods. Then what are the different types of cervical traction? Usually there are main two types. One is the Gardner well tongs, in which there are this is a crossbow type in which there are two pins which can be applied over the skull at specific points. Usually then there is a hook or the pulley through which a rope is applied, and along the rope there is a pulley which is usually present at the bedside or head side of the bed, and through that pulley weight is applied downward. So the weight provides apply cervical traction Usually the external acoustic meatus or the pinna usually 3 to 4 centimeter above the external auditory meatus. External auditory meatus usually 3 to 4 centimeter above the temporalis muscle. Usually these pins are applied, and when this is in the neutral position, when we want to achieve some flexion, then the pins can be applied 2 to 3 centimeter posterior to these pins, these pin locations. And when we want to achieve some extension, then these pins can be applied anteriorly approximately 2 to 3 centimeter. uh, then there is the halo ring or crown. Usually this is a full rigid full ring with the 4 pins. Core of the halo vest is sometimes present, and the most rigid external cervical immobilizer. There is a ring type uh, uh, crown or which we call the halo ring, is applied over the skull, and usually at the 4 points, two anteriorly and two posteriorly. And this is applied just below the widest diameter of the skull, and then we can achieve the cervical traction by applying this. So this is the halo device which we can apply. The halo crown, which is usually a ring that is applied just below the maximum skull diameter. Usually 4 pins are applied, two anterior and two posterior. Two anterior pins are usually applied 3 to 4 centimeter above the supraorbital margin, and posteriorly they can be applied uh, above the 3 to 4 centimeter above the external auditory meatus, and 3 to 4 centimeter behind the external auditory meatus. It forms a ring, and usually the cervical traction can be applied. And when achieving a long term traction, then this halo device or halo crown is attached with the halo vest. So when the halo vest is applied, so the long term cervical stabilization and traction can be achieved. Usually the supine position on traction, and align the pulley, and preparation pin sites with pyodine. Local anesthetic is applied up to the periosteum, and place pins 1 centimeter above pinna or 3 to 4 centimeter above the external auditory meatus, and then tighten side to side to the 1 mm indicator. Apply initial weight, then incrementally we can increase the weight with the serial imaging and neuro checks such as the post-op x-rays, and post-op serial neurology monitoring is also done after applying the cervical traction. And we can stop the reduction or stop applying the further weight when there is any neurological deterioration or over distraction after x-ray cervical spine is achieved. So usually we can start from the 10 pounds and add 5 pounds per level below the injury. There is no absolute maximum weight or that can be applied. Some say that up to 70 pounds, or some say in some research papers less than 50 pounds can is usually preferred. And usually unilateral facet dislocation needs more weight than bilateral, and retightened the uh, tongs once at Gardner well tongs once at 24 hours. Usually after 24 hours, we can further tighten the pins of the Gardner well tongs to achieve maximum stabilization. But after 24 hours, we should not usually further tighten the Gardner well tong pins, because further tightening can lead to the intracranial puncture. So we should apply the 10 pounds weight, then further increase the weight after applying next. After applying the increasing weight, we should do the little C-spine X-ray or C-arm, and when we have achieved satisfactory alignment by reviewing through the X-rays or C-arm X-rays, then we should stop the increasing the weight. And when there is neurological deterioration, we should also not increase the weight. Next. So post-op care, placement care, pin site care such as a clean daily or after alternate days, and watch for any discharge, redness or loosening of the pins, and retighten once after 24 hours. And hollow pins need to retorque to 8 pounds at 24 to 48 hours. And usually serial neurovascular checks and serial x-rays can also be done after increase of every 5 pounds weight, and guard the weights. Skin and prophylaxis such as pressure care, log roll, DVT, and pulmonary prophylaxis, because usually these patients are usually immobilized. And then usually the when the vest is applied to the halo traction, usually the wrench keep vest wrench taped to the vest for rapid removal if there is some uh, indication of any CPR or resuscitation attempt is required. So, for applying the halo vest, we should size the ring and vest, position the ring below the skull equator, that is the just below the maximum diameter of the equator, and tighten diagonal pin pairs anterior plus opposite posterior perpendicular to the skull, and then torque the four pins in 2 pounds increments diagonally to 8 pounds, and apply lock nuts. Apply the posterior vest shell. The posterior part of the vest is applied first, then interior, and then these are connected through a frame. Then confirm the alignment on radiograph, and then it needs to be readjusted at 24 to 48 hours. So the main complications are, that is the pin losing, that is the most common complication, and we should regularly check the pins of after applying the cervical traction. And then there is a pin site infection. There is over distraction, that is when there is neurological worsening, and dural puncture such as the CSF leak, intratable breach, pin pull out, that is scalp laceration can occur if the pin loses and due to the weight it pulls out. Others are such as the bed sores, dysphagia, or any nerve injury due to the over distraction can occur. So we have reviewed the different cervical traction types. What are the indications and contraindications? Usually, before the applying the cervical traction, MRI should be done, because in specific conditions such as the traumatic disc herniation, it can worsen the disc prolapse and worsen the neurology uh, after applying the cervical traction. So that is we should have a MRI before applying the cervical traction. Then we are going to discuss the uh, timing of surgery. Early decompression is always preferable, because in the latest research papers, such as that in the different meta-analysis and the different articles, they have compared the early versus late decompression. So the improvement in Asia impairment scale is greater than that is in if the Asia impairment scale is greater than 2, then early decompression. If the grade is 2 or 3, then early decompression uh, can have improved outcomes as compared to the late decompression. Usually, these are checked at the 6 month and 1 year outcome are compared, and in different such as uh, in one meta analysis, and in other researches, there is uh, uh, preferred results or increased outcome in early decompression within 24 hours as compared to the late decompression. Then timing of surgery beyond decompression. When there is no need to decompress the spinal cord, or when the injury is type that the spinal cord is not compressed due to any lesion, then the patient can wait, but we should do the surgery within the 72 hours. Usually within 72 hours are preferred, because due to the immobilization or hospital admission, further complications can occur, such as after early surgery, patient can early immobilize, and fewer pulmonary complications can occur because immobilization can lead to pneumonia, ARDS, and ventilator associated uh, complications. Then shorter stay and lower cost is also due to the uh, early surgery. Then damage control in polytrauma such as rapid posterior fixation and definitive surgery later. All these complications can occur due to the late surgery, and we can prevent these complications by early surgery, even if decompression is not required. Then this is the summary that we have discussed. The traction realigns and indirectly decompresses the spinal cord, and it realigns the normal anatomy. Then we have discussed the different, such as the Gardner Well tongs and versus halo, and never traction distractive surgery. Such We have discussed the absolute contraindications of cervical traction. Then decompress within 24 hours is